So let's take a closer look at this case. What we're dealing with here is a frontal chest radiograph of a skeletally mature patient, and right away something feels off about the left lung base. The left hemidiaphragm is strangely absent from its usual position, and the gastric fundus, well, that's missing too. Instead, what I'm seeing is a loop of bowel peeking through in the left upper quadrant, with an accompanying air fluid level that just screams something is out of place. Then there's the heart. The left border of it is partially obscured, which makes me suspect that something is definitely encroaching on the thoracic cavity. The first thing that jumps to mind here is a diaphragmatic hernia, possibly from a past trauma, although curiously, I don't see any immediate signs of rib fractures or pneumothorax that would point directly to a recent traumatic rupture. The right lung is clear, and there's nothing on that side to distract us from what's going on with the left. So, naturally, I start running through the possible differentials. A left-sided diaphragmatic hernia seems to fit the bill the best, most likely post-traumatic, even if that trauma happened long ago. Over time, it's entirely possible for organs like the stomach or bowel loops to herniate through the diaphragm into the chest cavity, especially after a tear or defect. That said, I have to keep my mind open to other possibilities. Could it be something like a cavitating lung lesion? Maybe, but that doesn't explain the absence of the gastric bubble or the presence of bowel loops. Hydrop pneumothorax? Sure, that could mimic some of these signs, but again, it's not the best fit here. Now, I'm already anticipating the next logical step. What further imaging would be necessary to confirm this? Without a doubt, a CT scan would be ideal. It would give us that cross-sectional view to clearly visualize any diaphragmatic defect and define exactly what's herniated into the thoracic cavity. And we can't forget about complications, right? A big concern here is strangulation of the herniated bowel. If that's happening, we're talking about a surgical emergency. There's no time to waste. And while we're at it, let's think ahead about some questions you'd expect to face discussing this case. You might be asked, how could this go unnoticed for so long? It's a fair question. Diaphragmatic hernias can remain asymptomatic for years, especially if the herniation is small or intermittent. The patient might only now be experiencing symptoms as more of the bowel gets involved, or if strangulation becomes an issue. Another likely question. What about trauma? Could this still be trauma-related even though there's no recent history? Absolutely. Traumatic diaphragmatic rupture can present months or even years after the initial insult. The patient could have had a minor injury years ago that led to a small tear, and now over time, the tear has allowed bowel loops to herniate into the chest. Before we wrap this up, remember that this isn't just about catching an abnormality. It's about thinking ahead and recognizing how these findings tie into the patient's history and possible outcomes. And of course, if you're enjoying these deep dives into radiology cases, don't forget to subscribe to Radiology Made Easy for more discussions like this. You'll get plenty of tips, tricks, and case reviews to keep you sharp and ready for anything.